Ladies and gentlemen, thank you so much for having invited me to address the MHOH forum, and it gives me great pleasure to do so from the World Health Organization here in Geneva, where I oversee the programmatic work of WHO. Now, I know that you're going to be discussing a number of issues, health issues, related to the local population, including the indigenous populations of your region, and that there are obviously a broad range of social, cultural, economic, and political factors that influence the dynamics of many of the diseases that are prevalent there, including the blood-borne viruses like HIV, viral hepatitis, and HTLV1. And as a result of these factors, some populations and communities are particularly vulnerable and disproportionately affected by blood-borne viruses, including many cultural and ethnic minorities. For example, migrants from high prevalence endemic countries may have been directly impacted by HIV or by hepatitis, and may have had family members who have become ill or died, and also have experienced financial hardship as a result of family ill health, medical costs, and they would have experienced being stigmatized and discriminated against, or actually living with one of the viruses themselves. For some blood-borne viruses, some indigenous populations are disproportionately affected, such as the very high prevalence of HTLV1 in some Australian Aboriginal communities. Of course, there are also certain cultural practices which could increase the risk of transmission of blood-borne viruses, such as the risks of HCV infection with tattooing and other body-piercing practices wherever infection control measures are not implemented. There are risks that individuals or even communities which live in these settings, in high burden HIV, hepatitis settings, could be stigmatized and discriminated against because of broader community perceptions that they actually pose a risk to the broader population by contributing to the spread of such viruses. There are, of course, also specific subpopulations in all countries that are at higher risk of HIV and viral hepatitis infection because of some aspects of their habits or their behavior or their inability to manage risks, which sometimes are not really within their control. And these groups of people at higher risk include sex workers, men who have sex with men, transgender people, people who use drugs, prisoners, and others in closed communities such as refugee camps and detention centers. It needs to be recognized that such vulnerable populations are also represented within culturally and linguistically diverse communities. Some of these populations, which are usually marginalized and stigmatized in the general community, may experience even greater stigmatization in their own communities, resulting in complex layers of stigmatization, discrimination, and marginalization. Such compounded stigma and discrimination often makes it particularly difficult for members of key population groups from culturally and linguistically diverse communities to access health and social services, even when these services are being provided to other members of their own community. The WHO's new 5-year strategy that we call the GPW13 aims to address some of the challenges experienced by particularly vulnerable and affected communities. And we believe in really the implementing the leave no one behind principles. Central to the strategy is the goal of achieving universal health coverage, where nobody is left behind, regardless of where they live or who they are, whether it's an indigenous person living with HIV, whether it's a migrant who is injecting drugs, or man who has sex with other men, or who's a member of a particular religious community. Universal health coverage is built on the principles of health equity, integrated services, and people-centered care. The GPW 13 believes in the 3 billion mission. So 1 billion more people who will be covered with universal health coverage, 1 billion more people protected from health emergencies, and a billion more people that are living healthier lives. And these billions really are based on the SDG targets. So if we do not achieve this by 2023, then we are unlikely to achieve the SDG targets by 2030. And of course, we are just about 10 or 11 years away from the SDG targets, not very far away at all. And therefore, we really need to now step up the pace at which we are implementing changes both within the health system but also outside the health system, what we call the multi-sectoral interventions, the policies and the regulations and the laws that need to change in sectors outside the health sector, whether it is agriculture, nutrition, food and civil supplies, education, social services, road safety, environment that affects air pollution, and so on. So there need to be interventions. A good example is tobacco, where, of course, we have the Framework Convention on Tobacco Control that most countries have signed up to, and that has gone a long way, really, in reducing the prevalence of tobacco use and smoking over the last decade. So similarly, now the world is talking about needing conventions for other major public health threats like air pollution or antimicrobial resistance. In 2016, the World Health Assembly adopted the 3 new global health sector strategies, including strategies for the elimination of AIDS, hepatitis, and the sexually transmitted infection epidemics by 2030. Those strategies outline priority actions for countries and for WHO to strengthen health systems in order to deliver essential HIV, hepatitis, and STI services to all those who need them. This includes defining essential packages of health interventions that should be delivered to specific populations and which ought to be covered by national health programs and budgets. Some of our biggest challenges going forward is going to be to reach those populations who are most vulnerable and marginalized, especially those who do not have easy access to healthcare, and to be able to deliver culturally appropriate and acceptable services. But at the same time, these need to be evidence-based and ensure that they are going to have the greatest impact. Whereas WHO develops normative guidance in the form of guidelines and standards, we promote research, we advocate for action, convene partners, and provide technical assistance. It is local communities themselves which should take control and lead efforts. It is encouraging to see such efforts, just like the ones that you're leading, the My Health, Our Health initiative, which is demonstrating such leadership in this area. I know that a number of you are general practitioners that work in this area and that know your communities very well, and you really are at the forefront of delivering quality health services to people living in these communities. And therefore, I think it is really important for you to not only deliver the care that people need, including mental health services, by the way, which have been neglected for many, many years, and we know that mental health is a major issue in most populations, constituting up to 10 to 15% of the burden of disease and burden of morbidity in communities, and requires special training and special skills, but it can be provided through nurses, through general practitioners to the community and make a big difference. Similarly, I think we also need to make sure that the feedback from groups such as yourselves feeds back to the policymakers who usually sit in the capital of the state or the city to ensure that the policies that are being developed are really addressing the priority health needs of your particular local community and local population. And it's been found in many situations where health policymakers make policies based on what they think is the evidence in front of them, when they actually have gone out and done surveys in the community to find out what people actually think. The list of priorities that they come up with are very, very different. In my own experience as a TB researcher, when I went to a remote tribal population to talk to them about TB and what we thought was a huge problem that needed to be addressed, the community members actually came back and said, well, TB is still relatively rare and we hardly get maybe one case during a year in this village, whereas our major problems are child care, child health issues. Children are still dying of pneumonia and diarrhea because we don't have access to services. And the other big problem was what do you do when there is trauma? When somebody has a fracture, for example, there is no care and you have to travel for hundreds of kilometers to access the specialist services. So it made me also think and realize that unless you really talk to the community members and find out what their day-to-day experiences are and what their felt needs are, we may be delivering services which are evidence-based and what we consider are addressing their needs, but still there's a gap between the two. So community participation in primary healthcare service delivery is very important because the other big advantage is they can also provide feedback and inputs into the quality of services that are being delivered and whether they are up to the mark or not. So there's a lot really to, I think, learn by just talking to each other and sharing experiences and then trying to focus on what are the major health issues of your community and of your region that you're trying to solve, whether it is alcohol and substance use, which is growing, or whether it's a question of sexually transmitted infections, which are still going unrecognized and undiagnosed. One needs to really have very targeted strategies and interventions that can make a dent on this, on these problems, which in that area constitute a big public health problem, but which in a neighboring state or province may not be the same. So again, the interventions really need to be driven by local disease burden and context. And in this case, I cannot overestimate the importance of having epidemiological data to really support such a targeted approach. So once again, it gives me great pleasure to have been able to share a few thoughts with you, and I do hope that your discussions will go well, and I look forward to hearing back from you as to what your deliberations were and whether you think the World Health Organization could support this area in any way. Thank you very much.